Good afternoon and good evening, everyone. And I'd like to welcome you all to this oral abstract session. I am Charlie Flexner from Johns Hopkins University. And on behalf of my co-chair, Angela Kashuba, we will be leading the oral abstracts followed by poster presentations for the next hour and 15 minutes. I would like to go ahead and start by introducing our first oral abstract presenter, who is Jin-Chang Yang from the University of California at San Diego. And he will be presenting a talk entitled Population Pharmacokinetics of HIV-specific broadly neutralizing monoclonal long-acting antibody VRC01LS in term infants. And following his talk and the next talk, we'll have 5 minutes for questions about the abstract presentations. So Dr. Yang, I'd like to turn it over to you.
Hi, my name is Jin-Chang Yang. I'm a second-year pediatric clinical pharmacology fellow at University of California, San Diego. Over the last year, I have been working with our mentor, Dr. Caprelli, on various pharmacometric projects. One of the projects we examined was a population pharmacokinetics analysis on VRC01LS, a broadly monoclonal neutralizing antibody. We assessed drug exposure in term infants following subcutaneous administration. The title of the presentation is Population Pharmacokinetics of HIV-specific broadly monoclonal neutralizing long-acting antibody VRC01LS in term infants. I have nothing to disclose. Despite advancements in antiretroviral therapy, there remains a need for innovative pediatric formulations to ensure compliance. Broadly neutralizing antibody, or BNAbs for short, are currently under development as prophylactic use and for the treatment of HIV infections. HIV prevention in breastfed infants especially remains challenging and requires more therapeutic options. As such, BNAbs can serve as a therapeutic option for these patients. Amino acid modification of Fc region of BNAbs can reduce clearance and extend duration of serum half-life to allow less frequent dosing. VRC01LS is the first long-acting BNAb that incorporates this Fc region modification for extended half-life. More specifically, it has 2 amino acid modifications in the Fc region and can extend the duration of its serum half-life up to 5-fold compared to VRC01. Mechanistically, this antibody blocks CD4-GP120 interaction to prevent viral entry. And this LS formulation is administered subcutaneously every 12 weeks or 84 days, whereas VRC01 is every 4 to 8 weeks, depending on the formulation. Here, I have listed the pharmacokinetic differences between VRC01 and VRC01LS in adults. These 2 amino acid changes provide 10-fold decrease in clearance and 4-fold increase in half-life compared to VRC01. To better characterize the pharmacokinetic differences between VRC01 and VRC01LS in infants, we conducted the VRC01LS population pharmacokinetic analysis from a phase 1 study, Impact P1112, following subcutaneous administration in early infancy. Here are the population included in our PK analysis, which included a total of 21 infants and 157 samples. The cohort was split into Arms A for non-breastfeeding infants and Arm B for breastfeeding infants. The infants were dosed based on body weight, as depicted here. So patients less than 4.5 kilograms received the 80 milligram dose, and those greater than 4.5 kilograms received the 100 milligram dose. The demographics between the 2 arms were similar. Please note that patients in Arm B, or the breastfeeding group, were provided with a second dose at week 12 for additional protection. For the model, the 2 arms were pulled together into a combined data set and was modeled using a 1-compartment model. Clearance was scaled to 0.85, while VD was scaled to 1. Age, captured as time greater than 12 weeks, was assessed as a covariate. Breastfeeding, sex, as well as location were also assessed. Next, a bootstrap with 1,000 iterations and a virtual predictive check were assessed for model validation. Lastly, we performed a Monte Carlo simulation to capture VRC01LS exposure and later on predict possible fallen concentration due to growth. The graph here depicts the overall plasma concentration profile for VRC01LS for each arm in log scale. On the y-axis, we have time after dose in weeks, and on the y-axis, we have VRC01LS concentration in micrograms per milliliter. The concentrations are stratified by study. Arm A is depicted here in black, while Arm B is depicted here in red. Please note that the Arm B received the second dose at week 12. During our pre-modeling analysis, VRC01LS concentration of infants follows the trend of a normal concentration profile for both arms. Since the plasma concentration falls mono-exponentially with time following subcutaneous administration and is log linear, we decided to go with a one-compartment model. To validate the model, both observed versus predicted VRC01 concentration and CW-res were assessed. The observed versus predicted VRC01 concentration is centered around the line of unity. In addition, CW-res versus time after dose is evenly distributed above and below zero, indicating no major bias in the model and no time-dependent kinetics nor dose accumulation. Here we have a virtual predictive check where we simulated a single 80 milligram dose in infants. The dashed line here represents a 95% confidence interval of the simulation. The red line here is the PD target of 50 micrograms per ml, and the blue is 20 micrograms per ml. The blue dots here are the raw concentration, and they fall reasonably within the confidence interval, indicating that the model is adequate. The final model parameter values are displayed in the table shown on the left. Following model building and for validation, we conducted bootstrap with 1000 alliteration, and its median value matches the final parameter values. Out of the 12 covariates screened, 1 covariate was kept in the final model. Age captured categorically as greater than 12 weeks or 84 days, the time when second dose is given, was best captured on VD. I want to bring attention to the equations on the right. Looking at the equation, our final model for parent clearance included allometry scale weight, which is scaled to 0.85. The equation tells us that heavier infants tend to have higher clearance. Since there is substantial growth during the first 12 weeks of life, from a median weight of 3.3 kilograms at birth to 5.7 kilograms at 12 weeks, there is a 59% increase in parent clearance during the first 12 weeks of life. Volume of distribution was scaled by weight and described by age effect. Using a typical 5.7 kilogram patient, the model predicted values slightly higher than normal infant plasma level, indicating that VRC01LS have limited ability to distribute into peripheral tissues. In addition, by factoring both growth as weight and categorical age, patients have substantial 37% increase in parent VD during the first 12 weeks of life. As the monoclonal antibody remains mainly in the plasma, there is a hemodilutional effect that contributes to the fall of VRC01LS concentration during growth. For the Monte Carlo simulation, we simulated patients receiving single subcutaneous dose of 80 mg, 100 mg, and sequential 80 mg followed by 100 mg after 12 weeks. For the study, the target VRC01 serum level is greater than 50 mg per ml for greater than 6 months, which is 10 times higher than the in vitro IC50 concentration of 5 micrograms per ml. This can neutralize the majority of circulating viral strains. In the article by Wu et al., 91% tested isolates have IC50 less than 50 micrograms per ml. This is depicted here in the figure to your right. The blue represents the concentration 1, red as 5, and dark red as 50 micrograms per ml. As you can see, a VRC01LS concentration of 50 micrograms per ml would cover IC50s for most tested isolates. For all three simulations, as depicted here, greater than 99% of simulated infants have C-trough greater than 20. However, this is substantially less for patients with C-trough greater than 50 micrograms per ml. Only 27% have C-trough greater than 50 micrograms per ml after a single 80 mg dose administration, and only 61% after sequential administration. So as a higher dose and more frequent administration will be needed to maintain a targeted serum level of greater than 50 micrograms per ml. In conclusion, the current study represents the first POP-PK evaluation of long-acting bNAbs in early infancy. Simulation of the current dosage studied is projected to maintain concentration greater than 20 micrograms per ml for 6 months in virtually all infants. Higher dose or more frequent administration will be needed to maintain concentration greater than 50 micrograms per ml in most of the infants. Also, we noted that there is a dilution effect from early growth that contributes to the fall in VRC01LS concentration. Lastly, I'd like to thank my mentors, the Impact Network, and my colleagues at UCSD for their support on this project. Without them, this project would not have been possible. Thank you for listening, and I shall take questions.
Thank you, Dr. Yang. I would invite the audience to please submit your questions using the question function in the on-air program. I hope it's obvious where you would be typing your questions and sending them to us. And as I said before, we'll be taking all questions for both abstracts after the second presentation. So I would now like to introduce our second presentation this afternoon, which is from Dr. Nicholas Katura from the University of Liverpool. And he will be presenting an oral abstract entitled In Silico Prediction of Intramuscular Long-Acting Rilpivirine in Liver Impairment with PBPK Models. Dr. Katura.
PBPK modeling is a quantitative tool that can be used for different objectives, and one of them is to describe the pharmacokinetics of a drug in a special population. In our study, this special population is the liver impairment 1. Liver-related diseases are one of the most non-AIDS-related causes of death among HIV-infected patients, accounting for almost half of deaths among hospitalized HIV-infected patients. Rilpivirine is an HIV drug categorized in the NNRTI therapeutic class and can be administered as an intramuscular long-acting formulation. The aim of this study was to develop and qualify a liver impairment PBPK model to predict rilpivirine concentrations following intramuscular administration in virtual patients with liver impairment. Liver impairment is described through the Child-Pugh classification. On the left, the table represents the clinical and lab criteria which have to be graded to evaluate the overall liver impairment stage. Each criteria can obtain 1, 2, or 3 points, and by adding score of each parameter, it gives the severity of the liver disease. 5 to 6 points for class A, 7 to 9 points for class B, and 10 to 15 points for class C. Categories are associated with different percentage of 1-year survival chance, 100%, 80%, and 45% for A, B, and C respectively. On the right, the other table summarizes the scaling factors used in the PBPK model for each liver impairment classification. Scaling factors are split into two types, fraction of control value and concentration. The scaling factor using concentration only is used to describe the protein plasma concentration. For the fraction control value, the parameter is decreased if the scaling factor is between 0 and 1, and the parameter is increased if the scaling factor is over 1. Here, the 6 parameters affected in liver impairment are the portal vein and hepatic artery blood flows, the gut enzyme quantity, the hepatic enzyme activity, the cardiac output, and the albumin concentration level. For an healthy volunteer, all the scaling factors are equal to 1. 2 available datasets have been considered for the optimization of the simulation of the Child-Pugh classification, and the publication selected is the one with the values presented here. On the right, the general structure of the PBPK model has been illustrated. The model comprises of compartments that represent organs and tissues connected together by the cardiovascular system. A well-stored and blood flow limited model was used, and simulations were done using symbology software. To correctly predict the rilpivirine concentrations, it is important to first qualify the model. For that reason, oral dose of rilpivirine in healthy and liver impairment classifications and intramuscular dose in healthy volunteer was used for the qualification. AAFE was calculated for comparisons against observed data. In general, PBPK models are considered qualified if AAFE is less than 2. Two formulations of ripivirine are available: the oral dose approved by the FDA for the treatment of HIV, and the intramuscular dose which is currently under investigation for the same indication. In order to correctly simulate the pharmacokinetics of ripivirine, it is important to provide a reliable representation of the different ADME processes. According to the literature, it was considered in the model that less than 1% of ripivirine is excreted as uncharged form in the urine and 26% in the feces, and that its metabolic clearance is fully operated by the cytochrome 3A4. On the right, in the table are summarized the physicochemical properties of ripivirine implemented in our model. For the ripivirine validation, two concentration time profiles were available, one oral and one intramuscular dose, both in healthy condition. For the oral dose, adults were given 25 mg daily, and the pharmacokinetic parameters as well as the concentration were considered as steady state. For the intramuscular administration, the subject received an intramuscular induction dose of 1200 mg, followed by maintenance intramuscular dose of 900 mg 28 days later. These conditions were replicated in silico, and the oral PK profile is presented on the right. The black dots represent the observed data, and the gray line and area represent the simulated mean plus minus the standard deviation. The resulting AFE for both doses, oral and intramuscular administration, have been detailed in the table on the left, and all of which are within the acceptance criteria. For the qualification of ripivirine in liver impairment classifications, the only information available was the reported percentage of increase or decrease of Cmax and AUC in Child-Pugh classification A and B. The same conditions were replicated in silico, and mean PK parameters were recorded for comparison and are available in the table on the left. At this stage, we consider that the model is in good agreement with literature data, which gives confidence for the prediction of intramuscular long-acting dose of ripivirine in liver impairment classifications. The same intramuscular regimen was evaluated in the three Child-Pugh classifications. The simulated AUC, Cmax, and Ctrough were listed in the table on the left, and the PK profiles are presented on the right. The black dots represent the healthy observed data, and the black line the healthy simulated profile mentioned in the previous slide. The mean concentration in Child-Pugh A, B, and C classification are represented by the blue, green, and red lines respectively. The percent changes of AUC, Cmax, and Ctrough were reported in the table for the three different liver impairment classifications, and we can observe a general increase of 40% in A classification, around 70% in B classification, and between 120 and 150% in C classification. There are two main limitations of this approach used in this project. Firstly, the Child-Pugh classification cannot always be suitable to categorize the liver impairment stage of patients in a clinical environment, and secondly, due to the lack of literature data available, ripivirine in Child-Pugh C classification was not validated, but we are currently working towards extending the qualification for this liver impairment classification to further increase the quality of the simulations. It is also well noted that despite passing the qualification criteria, PBPK modeling is based on multiple assumptions, including but not limited to the model structure and the tissue composition. To summarize, our simulations indicate that an intramuscular long-acting formulation of ripivirine may be suitable for the treatment of HIV in liver impairment classification regardless the Child-Pugh class, and more generally, PBPK modeling can be used to inform drug pharmacokinetics in liver impairment classification for different purposes.
Welcome back, everyone. And what I'd like to do now is to invite the speakers to turn on their videos, and as well as my co-chair, Angela Kashuba. And we'll be doing 5 minutes of questions on these two oral abstract presentations. So to begin, we have a couple of questions for Dr. Yang. The first is from Andrew Owen. And the question is, what do we know about sources of inter-individual variability in broadly neutralizing antibody exposure? Should we be thinking about variability in key genes involved in endosomal recycling for a VRCO1 LS, for example? And I'll let you answer that, Dr. Yang.
Yeah, thank you for the question, Andrew. So I'm actually not aware of any variability in the key genes that may involve or influence the degradation for the antibody. But for this study, it mainly captures the mostly pediatric. Well, all of them were pediatric patients. So the individual variability could be influenced from or impacted by the growth or the hemodilution changes for those infants, because each individual infants would have different, since there's hemodilution effect causing the decrease in clearance and also the change in the volume, growth can be a potential variability for this that could influence the individual variabilities. I hope that answers your question.
Great. Yes, thank you. So the next question, Dr. Yang, is also for you, from Laura Dickinson. And her comment is that in your model, you allometrically scaled clearance by an exponent of 0.85 rather than 0.75, which I suppose has been used for infants in some other settings. And her question is this specific for broadly neutralizing antibodies, or was there another rationale for using allometric scaling of 0.85 rather than 0.75?
Yeah, thanks for the question. So in terms of allometric scaling, it is for typical to use 0.75 for small molecules for infants or for any children's studies. But as for 0.85, the Genentech, there's articles in Genentech, as well as my colleague did further exploratory assessments and found it's better. They found that it's better to be modeled using 0.85 for the antibody scaling rather than the typical 0.75 for allometric scaling for pediatrics. So that's what we decided to go along with the 0.85 rather than the 0.75.
Okay, great. Thank you. So I have a question for Dr. Katura related to your presentation, and that is for drugs that are exclusively or nearly exclusively eliminated by cytochrome P453A4 metabolism. In other settings, for other small molecules where people have looked at the impact of varying stages of liver disease on pharmacokinetics, the earlier stages of hepatic impairment, for example, especially Child-Pugh class A, has little to no impact on systemic pharmacokinetics. And the interpretation of that usually is that it takes very advanced liver disease to reduce your 3A4 capacity to the point where you can see a reduction in clearance and an increase in systemic concentrations. But in your model, Child-Pugh class A did, in fact, your prediction was that Child-Pugh class A would increase concentrations of rilpivirine. And so my question for you, Nicholas, is number one, whether your model, your PBPK model, is more sensitive to hepatic impairment effects than we tend to see in the clinical setting, and whether or not your model actually took into consideration the fact that cytochrome P4 drugs that are exclusively cytochrome P453A4 substrates may require a higher degree of hepatic impairment to show an impact on systemic concentrations.
Yeah,
so I'll respond to that.
Yeah, thank you for your question. Yeah, it's true. There are several publications about the Child-Pugh classification for A, B, and C. So the one I used was Johnson, published in 2010. And it's true that the A classification has modification stronger than what we can see in a clinical environment, but the choice was to stick with the classification for A, B, and C because it was more reliable for the B classification. So for the A simulation, it could be over-predicting, but the idea was to stick with the overall classification from A to C.
Okay, great. And there is a follow-up question from an audience member who asked, who says that Child-Pugh did not appear to be a good measure of liver impairment in your model, and is there an alternative for future modeling? In other words, would there be a better way to model hepatic impairment that might be more predictive of changes in concentration rather than sticking with Child-Pugh?
Yeah, thank you again for the question. It's true. Type classification is not the only way to classify liver impairment, but for the modeling, it was the only liver classification available because for the rest, I didn't have any information about the enzyme activity, the liver function, or about the blood flow. So it's true, in a clinical environment, it's not the best way to do it, to use the type classification, but unfortunately for the modeling part, it was the only way to do it. So it might be interesting in the future to find a way to specify a more reliable and clinical scale for the liver disease and associate a number, a scaling factor for each class or classification for liver disease.
Thank you. And there, Dr. Katura, there's another question for you from Angela Colbert from Nijmegen. And her question is, what was the upper limit of rilpivirine concentrations that would still be acceptable? In other words, your model showed that all stages of liver disease resulted in increased rilpivirine concentrations, but your conclusion was that there would be no need for dose adjustment. And are there any concentration limiting toxicities for rilpivirine that might produce an upper limit of acceptability?
Yeah, thank you again for the question. Very interesting question, by the way. So yeah, there is a in vitro, so LD50, so the lethal dose, 50% of the people dying because of the dose, so it was evaluated. So it's very high. It's around 62,000 nanogram per ml. So even with the C classification, we are very far from this specific limit.
And what about QT prolongation? We know that rilpivirine has been associated with QTc prolongation. Is that something that's of concern in patients? Would that be something of concern in patients with liver disease?
Unfortunately, I don't know about the QT elongation. I couldn't find any specific concentration limit for that. So I couldn't implement it in the simulations. But it's a very good point, so I will try to search a bit more about it and try to connect the two.
Okay, terrific.
I'd like to thank Dr. Yang and Dr. Katura very much for their presentation in the first part of the session, and I know we have to move on now. So we're moving into the oral posters, and we'll be hearing from the following presenters: Teodora Pene-Dumitrescu, Parul Patel, Katie Moore, Mina Pastaga, Thomas Kakuda, and Joris van der Bosch. So after we hear from all of these presenters, they will join us for a Q&A.
And I'm a director in the Clinical Pharmacology Modeling and Simulation Group at GlaxoSmithKline. On behalf of my colleagues from ViiV and GlaxoSmithKline, I am presenting 3 phase 1 drug interaction studies investigating the next generation maturation inhibitor, GSK 3640254, which I'm going to refer to as GSK 254, with oral contraceptive ethinyl estradiol, levonorgestrel, with dolutegravir and tenofovir alafenamide and emtricitabine. For more information, I can be contacted via email on the email address found on this first slide. My conflict of interest is that I am an employee of GlaxoSmithKline. design. As you all know, there is still a need for new therapeutic agents for people living with HIV to meet a variety of unmet medical needs. GSK254 is a next-generation maturation inhibitor effective against a broad range of polymorphisms with no cross-resistance to currently approved antiretroviral HIV drug classes. The figure on the right shows the mechanism of action of maturation inhibitors as it was described last year and in 2015 at CROI. Since GSK254 is expected to be co-administered with oral contraceptives, DTG and TAF-FTC in a planned phase 2b study, here we describe the safety and PK results from 3 phase 1 drug interaction studies investigating GSK254 in healthy participants. The first study was GSK254 oral contraceptive drug interaction study. In terms of the design, which is illustrated at the top of the slide, this was an open-labeled, fixed sequence, one-way drug interaction study, which consisted of screening period, a check-in on day -4, a short run-in period from day -3 to day -1, where all participants received a daily dose of Porsche, and a treatment period with Porsche given either alone for 10 days or together with 200 milligram daily dose of GSK254 on days 11 to 21. All treatments were administered with a moderate fat meal. In total, 23 women were enrolled, the majority of which were not on hormonal contraception prior to the start of the study. In addition to serial PK samples for ethinyl estradiol and levonorgestrel, we also collected blood samples for progesterone, LH, and FSH, which are PD biomarkers for breakthrough ovulation. At the bottom of the slide in the table, we show the key PK and PD results, which show that co-administration of GSK254 with Porsche in the presence of a moderate fat meal did not impact the steady-state exposure of ethinyl estradiol or levonorgestrel, as illustrated by a geometric mean ratio of AUC and Cmax of approximately 1 and a 90% confidence interval within 0.8 to 1.25. In addition, there were no clinical trends in serum progesterone, LH, or FSH consistent with breakthrough ovulation. Moving on, here is a summary of the safety information for GSK254 oral contraceptive drug interaction study. The most common adverse events were transaminase increases and headache. With regard to transaminases, 8 participants had asymptomatic self-limited increases isolated to their ALTs and ASTs, 4 on Porsche and 4 participants receiving Porsche plus GSK254. The figure on the right shows box plots of ethinyl estradiol, levonorgestrel, and GSK254, segregated by the treatment either Porsche on Porsche or Porsche plus GSK254, and with the individual PK parameters color-coded by ALT, with green being normal, yellow being ALT greater than the upper limit of normal, and red being ALT greater than the 3 times upper limit of normal, which is the stopping criteria. The fact that the spread of the individual PK parameters is similar for all ALT subgroups indicates that there were no discernible trends in the PK parameters in participants without or with ALT elevations. These elevations are likely to be due to newly initiated treatment with hormonal contraception. The second study was GSK254 dolutegravir drug interaction study. In terms of design, which is again illustrated at the top of the slide, this was an open-label, fixed-sequence, 3-period, 2-way interaction study, which consisted of a screening period, followed by period 1, where participants received 50 milligram DTG for 5 days, a washout period, and then period 2, where all participants received 200 milligram GSK254 daily dose for 7 days, followed by period 3, where all participants received dolutegravir plus GSK254 for 7 days. All treatments were administered with a moderate fat meal. The key study results shown in the table at the bottom of the slide include show that there is no interaction between GSK254 and DTG, as illustrated by the AUC and Cmax geometric mean ratio close to 1 and 90% confidence interval within the 0.8 and 1.25 for DTG and GSK254 when given in combination versus the reference. The third study was the GSK254 TAF-FTC drug interaction study. In terms of the design illustrated at the top of the slide, this was an open label fixed sequence 2-period one-way drug interaction study which consisted of a screening period followed by period 1 where participants received TAF-FTC alone for 14 days, followed by period 2 where participants received TAF-FTC with 200 mg GSK254 for 7 days. All treatments were administered in the presence of a moderate fat meal, and the results shown at the bottom of the slide in the table indicate that co-administration of GSK254 with TAF-FTC decreased TAF exposure by approximately 11 to 12%. However, the exposure to tenofovir, which is the active moiety of TAF, and to FTC remained unchanged, as illustrated by a geometric mean ratio of approximately 1 and a 90% confidence interval for AUC and Cmax within 0.8 to 1.25. This slide shows the combined safety information from GSK254 drug-drug interaction studies with DTG and TAF-FTC. In both studies, most adverse events were grade 1 or mild, and there were no clinically relevant trends in adverse events, laboratory values, ECGs, or vital signs, indicating that co-administration of GSK254 with DTG or with TAF-FTC was well tolerated. In conclusion, the overarching conclusion for the 3 studies is that there were no significant PK or PD interactions precluding the co-administration of GSK254 with either oral contraception, DTG, or TAF-FTC, and that the results support the planned phase 2b study, with the recruitment planned for to start in October. Thank you.
Hello, I am Parul Patel, Global Medical Affairs Director from ViiV Healthcare, and I'd like to thank the organizers for selecting our abstract for an oral poster presentation. CAB and rilpivirine long-acting are administered as 2 separate gluteal intramuscular depot injections from which the drugs are slowly absorbed into the systemic circulation, resulting in sustained plasma concentrations over a 1-month or every 2-month dosing interval. CAB is metabolized via UGT1A1 with a minor UGT1A9 component, and rilpivirine is metabolized by CYP3A. Importantly, neither are inducers or inhibitors of metabolic enzymes. For most drugs with a standard PK profile, the persistence of drug in plasma is dependent on the rate of elimination and not the rate of absorption. Elimination is determined by the metabolism of the compound, so changes to metabolism lead to changes in the rate of elimination, which then lead to changes in the half-life. In contrast, long-acting drugs, such as CAB and rilpivirine, have rates of absorption that are significantly slower than the rates of metabolism. This leads to the phenomenon of flip-flop PK, where the terminal PK is moderated by the rate of absorption instead of the rate of metabolism. The 2 figures on the right illustrate these concepts and the consequences of altering metabolism through induction or inhibition. In the top panel, the PK profile for a drug with flip-flop PK shows this parallel shift up or down in concentration time course with an inhibitor or an inducer relative to baseline. So here you are changing the AUC, but not changing the half-life. In contrast, the bottom panel shows the typical situation for an oral drug with standard PK, where a metabolic inducer or inhibitor impacts the terminal phase of the PK profile, altering the gradient of the victim drug. So here you are changing the AUC and the half-life. Because CAB and rilpivirine are long-acting drugs with flip-flop PK, there are few clinically relevant drug-drug interactions during active therapy, as listed on the slide. So briefly, strong metabolic inducers are contraindicated, and caution is advised with sensitive O13 substrate drugs with narrow therapeutic index, such as methotrexate. Caution is also advised in individuals receiving chronic systemic anticoagulation given the IM modality of long-acting CAB and rilpivirine. Caution is also advised with drugs with a known risk of torsades. Following long-acting discontinuation during the PK tail, No drug-drug interactions with alternative heart are anticipated. And of note, metabolic inducers will not hasten removal of long-acting CAB and rilpivirine. Drugs that may be used without restriction with CAB-LA and rilpivirine-LA include the following: hormonal contraceptives, HPV and most HCV antivirals, most antibiotics, including IM formulations, gastric acid modifying agents, and drugs for other comorbidities. This slide summarizes established and other potential significant DDIs with long-acting CAB and rilpivirine. Drugs that are contraindicated include potent CYP and UGT enzyme inducers among the class of anticonvulsants, antimycobacterials such as rifampin and rifabutin, more than a single dose of dexamethasone, and the herbal St. John's wort. The support for this guidance comes from a variety of sources as listed. In addition, alternatives to the macrolides clarithromycin and erythromycin should be considered because of the risk of torsades with these drugs. And then finally, clinical monitoring is recommended as methadone maintenance therapy may need to be adjusted in some patients during concomitant administration with long-acting CAB and rilpivirine. Lastly, this table summarizes recommendations based on predicted drug interactions with CAB plus rilpivirine LA and select drugs that are commonly co-administered in persons living with HIV. Again, strong or moderate inducers of CYP and UGT metabolism are contraindicated due to the potential loss of efficacy and development of resistance. No clinically relevant drug interaction is expected with UGT1A1 or CYP3A inhibitors and long-acting CAB and rilpivirine. And gastric acid modifying agents such as antacids, H2 blockers, and PPIs can be given with long-acting CAB and rilpivirine because parenteral dosing bypasses the GI tract where this interaction is expected to occur. However, it's important to remember that these agents are still contraindicated or dose separation is required with the oral tablet formulations of CAB and rilpivirine. Thank you for your attention today, and for more information, I can be contacted via email, which can be found in this presentation.
Hello, everyone. I am Katie Moore, Head of Clinical Pharmacology at ViiV Healthcare. On behalf of my co-authors, Ilana Post, Savannah Maju, Mindy McGee, Pete Garicki, Pete Ackerman, and Cyril Lamoso, I'm excited to share the drug-drug interaction profile of the recently approved fostemsavir for heavily treatment-experienced patients with multi-drug resistant HIV-1 infection. Fostemsavir has a very comprehensive clinical pharmacology program with 27 phase 1 studies and 1 phase 2A study, many PK, PK/PD, and PBPK analyses. And so this presentation will focus on the application of results from the in vitro metabolism and transporter studies and all the clinical DDI studies. So let's begin with the highlights and the objectives. Fostemsavir is an oral prodrug of temsavir. Temsavir is primarily metabolized by esterases with CYP3A4 metabolism as a secondary pathway. This is where temsavir is a victim of DDIs. Temsavir is an inhibitor of BCRP and OATP1B1 and 1B3, and its two metabolites inhibit BCRP. This is where temsavir is a perpetrator of drug-drug interactions. Importantly, temsavir does not inhibit or induce major CYPs, UGTs, or other transporters that are detailed here. So the objective was to summarize the fostemsavir drug-drug interaction profile to inform co-administration with antiretrovirals and other drugs commonly used to treat individuals with HIV-1. Drug-drug interaction results were used to examine the impact of 14 drugs or drug combinations on temsavir pharmacokinetics, as well as the impact of temsavir on the pharmacokinetics of 10 other drugs. The results were summarized and applied to drugs with common underlying mechanisms. Clinically relevant temsavir drug interactions were based on temsavir exposure response relationships, which balanced the potential for Cmax-related QT prolongation while optimizing trough exposures for antiviral efficacy. Moving to the results, no significant interactions are expected across all currently available ARV classes: PIs, NRTIs, NNRTIs, integrase inhibitors, CCR5 inhibitors, and other entry inhibitors. And presented in the table to the left is a selection of these ARV classes and their impact on Temsivir. A full DDI profile for all ARVs is in the USPI. So let's take a closer look at strong CYP3A4 inhibitors, ritonavir, Cobi, boosted darunavir. As we know that Temsivir is a victim of CYP3A4, there is an increase in plasma TMR exposure up to twofold. For example, if you look at the last row with Cobi, there is a 1.93 increase in the AUC of Temsivir. But this does not require a dose adjustment because Temsivir Cmax remains below the threshold defined by the concentration QT relationship, which is more than fourfold higher than the approved dose. Moving to moderate CYP3A inducers, similarly, with moderate inducers such as etravirine or rifabutin, there is a decrease in plasma Temsivir exposure. But this does not require a dose adjustment because based on exposure response modeling with the phase 3 data from BRIGHT, there were no clinically relevant changes in virologic response. Moving to common drugs used to manage HIV and HIV co-infections or comorbidities, there are a few drugs that require attention from the HCP. Staying with Temsivir as a victim, strong CYP3 inducers such as rifampin, displayed in the first row of the table to the right, resulted in a significant reduction in Temsivir plasma concentrations. Of course, this may decrease virologic response and therefore strong CYP3A inducers are contraindicated. But remember, for moderate inducers such as etravirine or rifabutin, fostemsivir can be co-administered. Now let's examine Temsivir as a perpetrator. In an oral contraceptive DDI study, there was a 40% increase in ethinyl estradiol exposure and no impact in norethindrone. Because of this increase in ethinyl estradiol, we recommend the dose be less than or equal to 30 micrograms per day, and cautions advised for patients with additional risk factors for thromboembolic events. Because statins are OATP and BCRP substrates, we conducted a rosuvastatin drug-drug interaction study. And what we found was the 70% increase in rosuvastatin exposure with fostemsivir co-administration. Therefore, the recommendation is to use the lowest possible starting dose for a statin and to monitor for statin-associated AEs. And staying with that theme of Temsivir inhibition of OATP, although we didn't study these HCV agents, we anticipate an increase in grazeprevir and voxiloprevir concentrations, and if possible, use an alternative HCV regimen if possible. Lastly, since fostemsivir prolongs the QT interval at 4 times the recommended dose, caution should be used when co-administering drugs also known to prolong the QT interval. So in summary, fostemsivir can be co-administered with most common therapies used to manage HIV and HIV co-infections or comorbidities, including ARVs, drugs that increase gastric pH, strong CYP3A inhibitors, moderate CYP3A inducers, and therapies for opioid dependence. We'd like to thank all study participants and their families and the study investigators, as well as the scientists who contributed to this body of work over the years. Thank you very much for your attention and your interest. For more information, I can be contacted at the email address provided on the last slide. Thank you.
Thank you for the opportunity to present data for J&J's 644-17184, which is a non-nucleoside inhibitor of RSV polymerase. The study was conducted in healthy volunteers. This was a double-blind, randomized, placebo-controlled study assessing single and multiple ascending doses of J&J's 7184 in non-Japanese and Japanese healthy volunteers. Single ascending dose cohorts comprised of 8 volunteers, 6 receiving active drug and 2 receiving placebo. Non-Japanese volunteers were administered with either J&J 7184 drug product 1 at 40, 120, or 300 milligrams, followed by drug product 2 300 or 600 milligrams, or 300 milligrams of drug product 3, all under fasted conditions. After a 7-day washout, the same volunteers were administered 120 milligrams of drug product 1 and 300 milligrams of drug product 2 under fed conditions. Japanese volunteers were administered drug product 2 at 300, 600, or 900 milligrams under fasted. Multiple ascending dose cohorts comprised of 10 volunteers, 8 receiving active drug and 2 receiving placebo. Non-Japanese volunteers were administered multiple doses of drug product 2, consisting of 300, 600, or 900 milligrams once daily for 7 days, or a 600 milligram loading dose followed by 450 milligrams daily for 13 days, all under fasted conditions. Japanese volunteers were administered 600 milligrams of drug product 2 daily for 7 days under fasted conditions. For assessments, plasma samples were collected over 120 hours in SAD cohorts and over 24 hours on day 1 and day 7 or 14 in MAD cohorts, and analyzed using liquid chromatography with tandem mass spectrometry. PK parameters were estimated using non-compartmental analysis. Safety and tolerability were assessed throughout the study. Here, the mean plasma concentration time profile is shown for the SAD cohorts, including food effects. The terminal half-life of J&J-7184 was 17 to 22 hours across doses. Increases in maximum serum concentration, trough concentration, at 24 hours post-dose and area under the curve for 0 to 24 hours were dose proportional over the dose ranges for drug product 1 and drug product 2. Cmax ranged from 3 to 12 hours across doses and volunteers. Food increased exposure to J&J-7184 after administration of DP1 and DP2 and slightly delayed Tmax. Similar pharmacokinetics were observed in non-Japanese and Japanese volunteers. In MAD cohorts, steady-state concentration was achieved within 4 days with a 1.58 to 1.7-fold accumulation and exposure at day 7 relative to day 1. Cmax was 4 hours across doses in volunteers. Except in Japanese volunteers who were administered with 600 milligrams of DP2 daily for 7 days, whereby it was 2 hours. Exposure was approximately 19% less in Japanese volunteers at day 1 versus non-Japanese volunteers. Pharmacokinetics were similar between groups at day 7. In total, 12 treatment-emergent adverse events were observed during single dosing. All were considered mild or moderate, and only 2 were considered related to J&J-7184. No treatment-emergent serious adverse events were observed during multiple dosings of J&J-7184, and the 32 observed treatment-emergent adverse events were considered mild or moderate. We observed a similar number of AEs in drug-treated volunteers as those who received placebo. Dizziness was considered possibly related to high doses of J&J-7184 occurring at 900 milligram doses. In summary, single and multiple dose administration of J&J-7184 was generally safe and well tolerated in healthy volunteers. Exposure increased in a dose proportional manner. PK was similar for non-Japanese and Japanese volunteers following single dosing of J&J-7184, whereas for multiple dosing, slightly higher exposure was observed at day 1 in non-Japanese versus Japanese volunteers and was similar between groups by day 7. Multiple dosing achieved plasma concentrations within the anticipated therapeutic range of these healthy volunteers. Future studies will evaluate J&J-7184 in adults infected with RSV. Thank you for this opportunity to present our data.
On behalf of my colleagues, I'd like to thank the conference organizers for selecting our abstract as an oral poster. J&J-3989 is a fixed-dose combination of 2 small interfering RNA compounds, J&J-3976 and J&J-3924, in a 2-to-1 molar ratio. Both compounds can be represented by the single figure below. On the left-hand side of the molecule are 3 N-acetylgalactosamines, which serve as a ligand for the hepatic asialoglycoprotein receptor. The pharmacologically active portion of the molecule shown on the right is double-stranded RNA, 21 nucleotides in length. This is also referred to as the RNA interference trigger. The nucleotide sequences are complementary to the mRNA produced from the HBV genome illustrated here. 3976 targets the S open reading frame, whereas 3924 targets the X open reading frame. Together, the two RNA triggers are designed to target all HBV RNA transcripts derived from covalently closed circular DNA, as well as transcripts derived from integrated viral DNA. Once delivered to the hepatocyte, the triggers are internalized and become loaded onto the RNA-induced silencing complex. The loaded RISC then cleaves HBV mRNA in a sequence-specific manner. This activity is continuous, allowing for once-monthly dosing. Proof of concept was recently presented by Dr. Gain at EASL last month. Patients with chronic hepatitis B were administered J&J 3989 100 to 400 milligrams subcutaneously every 28 days for 3 doses with nucleoside analogs. 39% of patients were able to sustain 1 log or greater reduction in hepatitis B surface antigen for 48 weeks after the last dose. Single-dose pharmacokinetics of J&J 3976 and J&J 3924 were evaluated in healthy volunteers from 2 phase 1 studies. ARO-HBV 1001 was the first in-human single-ascending dose study evaluating doses between 35 and 400 milligrams in the non-Japanese population. For each dose, 6 subjects were enrolled, 4 on active, 2 on placebo. Subsequently, we designed a Japanese PK bridging study, the HPV 1001 study, to assess in parallel 3 doses, 25, 100, and 200 milligrams. For each dose, we enrolled 8 subjects, 6 on active, 2 on placebo. In both studies, plasma PK was measured over 48 hours. In the ARO-HBV 1001 study, we also collected urine PK over 24 hours. PK parameters were estimated using non-compartmental analysis, and a pooled population PK model was developed using non-MEM. Safety and tolerability were assessed throughout. In general, few adverse events were reported in both trials. The most common adverse event occurring in at least 1 healthy volunteer is provided in the table. These adverse events were equally distributed between active and placebo subjects. All adverse events were reported as either mild or moderate. Injection site reactions were reported in 4 subjects, 3 on active, 1 on placebo. In the upper right quadrant, I present the plasma concentration time curve for 3976 on the left and 3924 on the right. Solid lines represent the ARO-HBV 1001 subjects, whereas the dotted lines represent the subjects from HPV 1001. The colors correspond to the doses in the table. In the table are the derived pharmacokinetic parameters. On the top is J&J 3976 and on the bottom is J&J 3924. In general, plasma half-life was 4 to 6 hours for both compounds. In general, exposure increased in a dose proportional manner up to 300 milligrams. At 400 milligrams, it was less than dose proportional. When comparing the 2 studies, Japanese subjects at the 100 milligram dose appeared to have higher Cmax and AUC relative to the non-Japanese in ARO-HBV 1001. At the 200 milligram dose, both Cmax and AUC were comparable. Both 3976 and 3924 were renally eliminated in a dose-dependent manner. The amount excreted ranged from 20 to 42% of the dose. In conclusion, J&J 3924 and 3976 have short plasma half-lives consistent with other GalNAc siRNAs. This suggests rapid hepatic uptake. Plasma exposure generally increased in the dose proportional manner, and no clinically relevant difference in PK was observed between the non-Japanese and Japanese population. Renal elimination was dose-dependent, and single-dose subcutaneous administration of J&J 3989 was generally safe and well tolerated. Several phase 2 studies of J&J 3989 are ongoing in patients with chronic HBV or HBV-HDV co-infection. Lastly, I'd like to acknowledge the participants and the study sites, as well as my colleagues at Janssen and Arrowhead Pharmaceuticals. Thank you for your attention.
Hello, I'm Joris van den Bossen. On behalf of my colleagues at Janssen, I'll be presenting results of a study on the effect of multiple-dose itraconazole on single-dose J&J 6379 pharmacokinetics. 6379 is a HBV capsid assembly modulator that induces formation of normal but empty non-functional HBV capsids, CAM-normal, thereby blocking HBV replication. 6379 also inhibits de novo formation of covalently closed circular DNA, secondary mechanism of action. In ongoing phase 2 studies in chronic hepatitis B patients, 6379 is combined with J&J 7376 3989, short interfering RNA, a nucleoside analog, as well as PEC interferon alpha. 6379 is mainly metabolized by cytochrome CYP3A4, is a CYP3A4 inducer and a substrate of breast cancer resistance protein, as well as P-glycoprotein. 15% of an oral dose of 6379 is eliminated as unchanged drug in urine. Therefore, there is potential for drug-drug interaction when J&J 6379 is co-administered with a CYP3A4 inhibitor. Itraconazole was selected as potent and competitive inhibitor of CYP3A, but also is a substrate of CYP3A4 and a potent BCRP and P-glycoprotein inhibitor. In healthy adults, we investigated the effect of itraconazole after repeated administration on the PK of a single dose of 6379 and safety of the combination. Study was open label with a fixed sequence and recruited in a single center. Design figure. Treatment period 1, a single oral dose of 6379 to 50 mg given with food. A washout period of at least 33 days allowed for elimination of 6379. Treatment period 2, itraconazole given 5 times a single oral daily dose of 200 mg fat condition. Treatment period 3, single oral dose of 6379 to 50 mg given together with food, while itraconazole was continued up to day 54. Follow-up was 33 up to 38 days after last administration of 6379. Results. 16 volunteers enrolled, 3 discontinued prematurely, 1 in each treatment period. PK parameters were evaluated in 16 subjects for reference, 14 for test. Figure with mean plasma concentration profiles illustrates that plasma concentrations of 6379 were higher during co-administration of itraconazole compared with those following 6379 alone. Table with PK parameters. Presence PK parameters of 6379 in absence of itraconazole as reference and in presence of itraconazole as test. Differences were more marked in the elimination phase captured by AUC 0408 hours versus the absorption phase. Mean total amount of 6379 in urine was 1.30-fold higher and renal clearance 1.50-fold higher during co-administration with itraconazole. Statistical analysis. During co-administration, Cmax was slightly higher, as well as initial AUC 072 hours, still within 81-25% limits of confidence interval. Differences became more pronounced for AUC 0408 hours. Ratio for AUC was about 40% higher and outside 81-25% limits. Pre-dose itraconazole plasma concentrations increased between day 36 in period 2 and day 55 in period 3 from 61 to 527 nanogram per. Safety. Treatment emergent AE were mild to moderate in severity, with headache most common. On last day of treatment period 2, one subject was discontinued by investigator after observation of increased amylase assessed as a grade 1. In treatment period 3, one volunteer withdrew from the study due to a serious AE. This was a grade 2 pneumothorax, categorized as unrelated to any treatment. Subject received 2 doses of 6379, 18 doses of itraconazole. Only treatment-related adverse event, hypercholesterolemia in one subject, considered as possibly related to itraconazole, doubtfully to 6379. In conclusion, co-administration of multiple doses of itraconazole with a single dose of J&J 6379 moderately increased exposure of 6379. It is expected that a similar increase of 6379 will be observed during co-administration of multiple doses of a CYP3A4 inhibitor and 6379. Single dose of 6379 with or without multiple dose of itraconazole was generally well tolerated, no clinically relevant dose or concentration related safety issues. Thank you.
Thank you so much to all of our presenters. A lot of wonderful data here. And we will be starting the Q&A. So we have a number that have already been entered here that I'll start with. But don't forget to please continue to enter any questions that you have. So the first one is from Angela Colbers for Dr. Pene Dumitrescu, and that is, how is GSK254 metabolized and eliminated? Does GSK254 induce or inhibit enzymes?
Yeah, thank you for your question. So with regard to metabolism, GSK254 is metabolized by CYP3A4, CYP3A5, CYP2C9, and CYP2C8. With regard to excretion, we are currently have an ongoing human ADME study, so we do not know the human excretion. However, based on preclinical data that we have on hand, this indicates biliary excretion coupled with fecal elimination.
Okay.
In terms of does GSK induce or inhibit enzyme? At the maximum projected clinical dose, there is a very low risk of CYP inhibition, and this is based on either direct or time-dependent inhibition of these enzymes. There is no induction of CYP3A4, CYP2B6, or CYP1A2, and GSK254 is an inhibitor of OATP1B3 and MRP2, and it's also an inhibitor of UGT1A1.
And Angela's second question is, what could be the reason for the lower TAF exposure when combined with 254?
Yeah, thank you for this question. It's a good question. We never had a good rationale for the slightly lower TAF exposure when given in combination with GSK254. But again, this is a very small decrease in exposure, and the clinically relevant tenofovir concentrations, which is again the active moiety, they remain unchanged. Thank you.
Thank you. The next question is from Andrew Owen for Dr. Patel. How much is known about the depot site, metabolism and transport, or potential novel DDIs that are mediated through mechanisms involving granuloma formation? Oh, Dr. Patel, I think you're muted. Cannot hear you.
She should be okay now, Dr. Patel. Try again.
No, still not happening. Well, maybe we'll see if Patrick can work on that in a second, and we'll come back to that question. Let's see. So Kim Scarcy had a question for Dr. Moore, and that is, can you discuss the proposed mechanism for the observed DDI between ethinylestradiol and fostemsavir?
Absolutely. Thank you for the question. And for that particular interaction, what we see is an increase in the early part of the profile and no change in the elimination rate. And so what we think is the proposed mechanism is inhibition of CYP3A4 by the metabolite and very minor CYP3A4 inhibition at the intestinal wall. And so what we see with CYP3A4 substrates such as maraviroc, we see about a 25% increase with methadone, and with buprenorphine, we see anywhere from 10 to 30% increase. So these are markers to say that there is slight inhibition of CYP3A4 by this metabolite, but they're not clinically relevant.
Thank you. There's also a question from Jules Levin about fostemsavir, and that's, what about other HCV DAAs?
So, we conducted a rosuvastatin drug-drug interaction study, and that was a really important study because it was used as a benchmark. We saw a 70% increase with rosuvastatin. And so that helps us benchmark across both use with statins, with which HCV DAAs. And what we really found was we don't expect clinically relevant interactions. And the interactions that we have in labeling for Grizepivir and Voxiloprivir is mainly because of the association that was found with increased late-stage ALT and AST elevations with Grizepivir, anywhere around 5-fold increase in their concentrations. And with Voxiloprivir, again, it's very sensitive to OATP1B1 and 1B3 inhibition. So we're just saying it's not recommended, but other agents should be considered, but we are not expecting clinically relevant interactions for the most part with HCV DAAs.
Just to follow up on that one, another one for you, Katie, and that's with the statin interaction and TMR, would it be more serious if a patient is also on a boosted PI?
So boosted PIs will trump it. Yeah. And so again, you're looking at a 70% with TMR or fostemsavir, and with atazanavir, you get about a 3-fold increase. With cyclosporin, you get about a 9-fold increase in rosuvastatin. So really, all those agents trump timsavir's impact, and so you start with the lowest dose and try to titrate to effect.
Okay, and one more for you, Katie. Did you mention DDIs with dolutegravir or TAF? Tim Cressy would like to know about those.
Yeah, those are good questions, Tim. Thanks. So for dolutegravir, we have not, for either of those agents, we haven't conducted any studies. However, we have data with ralotegravir, which is in the label. There was no interaction. We have interaction with tenofovir in the label, and there was no interaction. But getting back to OATP1B1 inhibition, because TAF is a substrate, we are expecting that TAF concentrations would increase, and we're predicting the increase would be about on the same magnitude as COVID.
Okay. Let's check back in with Dr. Patel.
Great. Can you hear me now?
Ah, beauty. Okay.
I don't know what happened.
Do you want me to repeat the question, or are you good?
Yes, please.
Okay. So it comes from Andrew Owen, and it's about the depot site and potential novel drug-drug interactions that are mediated through mechanisms involving granuloma formation or other things.
That's a very interesting question, Dr. Owen. So we have not actually evaluated the possibility of DDIs that could be mediated by changes to metabolism or transport at the level of the injection site depot. However, we do know that both CAB and rilpivirine have very high bioavailability after IM administration. The absorption rates are consistent and do change over time. They're primarily metabolized, obviously, in the liver. So we think that there's going to be a very low likelihood of DDIs at the depot site, but certainly something we haven't studied in any sort of detail.
Thank you. Charlie, you also had a question for Dr. Patel. Would you like to ask that one?
Sure. I'll go ahead and ask it live. So, Dr. Patel, I love your presentation. I love the use of modeling and simulation to predict drug-drug interactions with long-acting formulations. But I'm wondering about the degree of confidence in some of those predictions, and specifically, do you think there are classes of drugs or specific agents where the outcome of a drug interaction would be so unpredictable that one would need to pursue studies in human volunteers or in patients?
It's a very good question. So we have used the oral formulations of both CAB and rilpivirine to really study the impact of changes in metabolism or transport as a result of drug interactions. The only ones that we haven't, obviously, are at the level of absorption, which can be difficult, as you can imagine, because we're looking at an IM mode of delivery. So I don't believe there are classes of medications or specific agents that could appreciably change the dynamics at absorption. But again, like Dr. Owen had sort of a similar question, we haven't interrogated that very fully. So it's an interesting question, but we don't believe that there's a good likelihood with the most common classes of medications we're using in our HIV-infected patient populations.
So there's a similar question from Scarzy around this. Do you have plans in place to validate the DDI potential in clinical studies, or do you think the models with the oral agents are sufficient?
Right. So I think Marta Buffito very eloquently at the beginning of the session today, talked about some of the challenges with trying to do a long-acting drug-drug interaction study. And so we really feel that using the oral formulations where you're showing sort of the worst case scenario, because you have, higher exposures, more of that peak trough variability with oral dosing relative to the long-acting, that we've been able to really characterize and predict what the long-acting drug-drug interaction potential is. So, unless there was a more, practical way of doing a long-acting drug-drug interaction studies, we feel the modeling and simulation is sufficient to characterize, any potential risks.
Thank you so much. And for Dr. Kakuta, from Heather Savinsky, given the siRNA's rapid elimination from plasma and the long duration of activity, is plasma PK a good marker to assess similarities between populations?
Yeah, very good question. I think, plasma pharmacokinetics are certainly the easiest things to collect for the siRNAs, but your experience with nucleoside analogs, for example, it's really the liver concentrations or the intracellular concentrations that are probably more important, but that obviously requires liver biopsies, which are not as easily obtained. So, in terms of the reason why we looked at the Japanese, non-Japanese is primarily a regulatory requirement for our study to proceed in Japan. They wanted to see some pharmacokinetics in the Japanese population, and that was really the reason why we conducted that study. But no, I don't think plasma concentrations are probably the best marker, but it is the easiest to obtain.
Yeah. And so kind of a follow-up question from Timothy Ellie, and that is, would you have expected any ethnic differences with this formula?
No, we didn't expect any ethnic differences. So we looked in the literature for differences in the asialoglycoprotein receptor, anything that might affect the nuclease, difference in nuclease activities, for example. That's how they're metabolized. We couldn't find anything that we would expect a difference. And again, it was primarily more for regulatory reasons why we conducted the Japanese PK bridging study.
Okay. Thanks so much. Well, I'd like to thank all of the speakers for the excellent science today. I'd like to thank all of the participants for their great questions and for joining us and hanging in there. We're just a few minutes over time. And we will see you tomorrow at 10 a.m. Eastern. Have a terrific rest of your day.